Hello dear colleagues, friends and followers. Welcome to the ACC 2020 wrap-up by the Thoraxcenter for Radcliffe Cardiology. My name is Nicolas from Mieghem, and next to me, from a distance, as always, my good friend and colleague Joost Daemen. We are all together in this COVID-19 pandemic. Let me start by saying I hope for all the best for you and your loved ones. Governments throughout the world have taken drastic measures to help secure communities and people, and I may not agree with some of the principles of dealing with this pandemic. I will follow what is asked by the political leadership. It will take time to recover from this as a society and a medical community, but I don't think we have any other options. In the meantime, on a personal level, I decided to take my responsibility and cancel all my upcoming face-to-face meetings until June 1st. I must say I appreciate the firm and determined decision by the ACC to transition this year's event into a virtual experience that will include late-breaking clinical trials. So here we go with our take of the interesting late breakers at the ACC 20 WCC Virtual Congress. As always, antithrombotic regimens remain a hot topic, both in the coronary and structural heart space. Joost, let's kick off with the Taylor PCI trial.
Yeah, so welcome everybody. So the Taylor PCI trial is one of the first late breakers that will be presented online. So this is a multi-center, a prospective open-label randomized controlled trial which enrolled over 5,000 patients elected to undergo PCI for either stable angina or acute coronary syndrome, which were then one-to-one randomized to either clopidogrel or clopidogrel plus CYP2C19 testing, and in case of a loss of function allele mutation, switch to ticagrelor. Patients will be followed for MACE at 1 year. So a little bit of background, please remember. So clopidogrel, as you all know, is a prodrug that needs activation in the liver by this enzyme called CYP2C19. This is important since 18 to 40% of the patients turn out to have this loss of function allele gen mutation, which actually then results in a high residual platelet reactivity because of the fact that these patients simply cannot metabolize clopidogrel and thereby end up with a drug that doesn't do what it's actually intended to do. So at present, little is known about the potential of CYP2C19 testing in routine practice and what acting upon that in routine practice would mean in terms of achieving better outcomes in patients. This study follows a little bit on the discussions of already a decade ago on causes of stent thrombosis. And also more recent discussions on, for example, co-medication with PPIs like omeprazole that is also activated in the liver by the same enzyme, and thereby led to recommendations to, for these patients, switch to for example, pantoprazole in patients that receive clopidogrel. Moreover, what I find interesting in this trial that it also again includes ACS patients. So you know these patients are usually, according to all guidelines, deemed to get third generation P2Y12s like prasugrel or ticagrelor, but in this study they are not. They are either getting clopidogrel or only ticagrelor in case of CYP219 genetic mutations as established by point of care testing. Interesting also, this follows the popular genetics trial, which actually did the exact same thing, but then in STEMI patients who were also randomized to either clopidogrel or clopidogrel plus testing, and in case of CYP219 genetic mutations, switched to ticagrelor. This trial was positive because it showed non-inferiority in terms of MACE, but did show an advantage for patients treated with clopidogrel in terms of bleeding. So thus far, Taylor PCI.
So does it also mean that patients with stable coronary artery disease, if they would be a clopidogrel non-responder, they will be switched to ticagrelor?
Yes.
Like full dose?
Exactly, and this is actually a very interesting concept because it follows a little bit the hypothesis that many people have raised about, for example, Plato and Triton, is that the benefit of prasugrel or ticagrelor respectively is potentially due to the fact that clopidogrel simply is not effective in, let's say, 1/3 of the patients. Not because of it's a more potent drug per se, but because the fact that it acts, let's say, more reliable in a general patient population.
There is also a sub-analysis from the Augustus trial on optimal antithrombotic regimes in patients who are on oral anticoagulant drug therapy and undergo PCI.
Yes, that's true. So remember, Augustus was a large randomized controlled trial with a 2x2 factorial design that randomized almost 4,600 patients to either vitamin K antagonist or NOAC, and then subsequently to either aspirin or placebo on top of routine therapy of 6 months, P2Y12 inhibitor, which was mainly clopidogrel in this trial. So I'm not exactly sure what this subgroup analysis of the study will entail, because it enrolled a rather diverse patient population, being either elective PCI cases, ACS patients plus PCI, or ACS patients that were managed conservatively. So all these patients will have had different loading strategies, etc. And you need to consider the fact that in this trial, patients were randomized within the first 2 weeks. So there might be a little bit of diversity in how patients were managed, at least in the first month. So at the end, I think I can only imagine that this trial will only strengthen the findings of trials like Global Leaders and like Twilight, really questioning the need of aspirin on top of specifically the more potent P2Y12 inhibitors, or patients being on NOAC or OAC.
Well, I think especially in patients who are on oral anticoagulant drug therapy, even in our practice, we no longer prescribe aspirin. I mean, I already stop aspirin after the PCI these days, so patients only are taking a NOAC or oral anticoagulant vitamin K antagonist in combination with clopidogrel these days.
Yeah, that's true.
The group of Joost and Berg from St. Antonius Hospital in Mieghem will continue their Herculean efforts in this pharma space and now move to the structural heart arena with the popular TAVI trial. This trial will study the role of clopidogrel in patients after TAVI on top of either aspirin, which is cohort A, or oral anticoagulation, which is cohort B. At this meeting, Vincent Nicolas, one of his fellows, will present cohort B, and it is a very relevant question because clopidogrel use with TAVI is empirical and not evidence-based. Overall, 1,000 patients will be randomized in the global popular TAVI trial. It is not clear to me how many patients will feature in cohort B. Also, the trial started its enrollment in 2014, so I want to know how many patients will be on a NOAC rather than vitamin K antagonists. As a matter of fact, it might only include patients on vitamin K antagonists because the protocol explicitly stated that patients were not to interrupt oral anticoagulant drug therapy and strive for an INR of 2 at the procedure time. The primary safety endpoint is any bleeding event at 1 year, and the co-primary endpoint is any non-procedure related bleeding at 1 year. This cohort B is the next offspring of the popular series and zooms in on TAVI in patients on oral anticoagulant drugs. I predict there will be harm in adding clopidogrel to oral anticoagulant drugs, and in our practice, again, we already moved away and dropped clopidogrel in patients on these drugs. And this trial precedes the envisaged TAVI-AF trial that compares edoxaban with vitamin K antagonists in patients undergoing TAVI. That trial completed its enrollment early January, and data are expected next year.
Yeah, so I fully agree, and I'm confident that in patients without concomitant coronary artery disease, monotherapy is the way to go. However, since most of the bleeding in these patients occurs per-procedural and local loading strategies might have a significant impact. So I'm curious to see how this trial would take that into account.
Next topic in the valve space compares vitamin K antagonists with edoxaban in patients after surgical mitral repair or surgical mitral or aortic valve replacement with a bioprosthesis. The ENAVL trial is a Korean single-center initiative to enroll 220 patients who were included starting 7 days after surgery and then followed for 3 months. The primary endpoint was the occurrence of thromboembolic events and the presence of any thrombus as determined by MSCT or echo. This trial mixes mitral and aortic cases, and I wonder whether we should do that. Thrombogenicity at the mitral valve is a totally different concept from the aortic valve. So this trial will probably end up being underpowered and hypothesis generating, I guess.
Yeah.
Okay, so there is also an interesting trial on the way in EP space.
Yes, so you know EP is not our core business, but this trial stood out to us because it features several things that might be of interest from a more general perspective. So Venus was a randomized controlled trial that randomized over 400 AFib patients to either pulmonary vein isolation or pulmonary vein isolation plus concomitant vein of Marshall ethanol infusion. Patients will be followed then for 6 to 12 months for AFib burden monitored with dedicated event monitors, which I think is a very good thing. But then the question, have you ever heard about the vein of Marshall? I hadn't.
course.
Of course you did. So for those of you who haven't, we have a small animation for you showing you the vein of Marshall, which is actually the side branch of the great cardiac vein. So interestingly, the vein of Marshall contains myocardial connections and abundant sympathetic and parasympathetic innervation implicated in the genesis and maintenance of AF, and is anatomically co-localized with the mitral isthmus, the ablation target of perimitral flutters. And it's exactly these flutters that are known to be one of the recurrent issues of failed pulmonary vein isolation. And it's actually thus far that strategies to improve the outcome of ablations in these patients with more additional lesions beyond PVI have not consistently shown benefit. And it's exactly the recurrence as perimitral flutter that has been recognized as a recurrent phenomenon. And that's exactly the target that potentially could be targeted with the ethanol infusion in the vein of Marshall. To me, this trial is of interest, since it's again a trial that studies the effect of additional treatments focusing on the sympathetic or parasympathetic nervous system in order to improve diseases like AFib that have been linked to sympathetic nerve activity. And that is interesting because it adds to, for example, a recent trial on the additive value of renal denervation in these patients, which also proved to be very positive. On the flip side, the vein of Marshall is a anatomical structure that might also suffer from a lot of anatomic variation. So I'm not sure how reliable this therapy can be applied in a routine patient population, but I guess that will be addressed in the presentation of the trial.
But it's an embryonic remnant, and is it there in all the patients and everybody?
Yeah, so that's my question as well. I'm not that much into the material to give you a definitive answer, but I think in the presentation they will definitely come back to that.
So does this mean that pulmonary vein isolation is not the holy grail? Because now the EP world is looking for additional therapies, additional treatments.
It's a good question, and on the flip side, I think we need to be honest. There are little therapies in medicine that are effective in 100% of the patients, and the same counts for PVI, it counts for CRT, but the same is true for PCI, which also doesn't resolve in China. Doesn't result in China really even 100% of the patients.
Okay. Next up, the Medtronic Tavern low-risk bicuspid study. This trial is a multi-center prospective trial including 150 patients, 60 years or older and at low operative risk. That is remarkable to me, because low risk in combination with bicuspidi. It makes me wonder why these patients were selected for TAVI and not for surgical aortic valve replacement outside of a randomized setting, so quite provocative. This study has a primary composite clinical endpoint of death and disabling stroke, and the trial precedes the Bivolute X trial that will also include 150 patients but at higher operative risk and with meticulous imaging follow-up including MSCT. Bivolute X will evaluate different sizing algorithms and was set up as a late breaker at the upcoming EuroPCR meeting. So renal denervation, Joost, is also again a hot topic. Which trial to look for?
Yeah, so at the ACC will be the congress for Medtronic with the final release of the results of the pivotal trial. So the Simplicity HTN off-med trial with the final results will be presented. So along with the Radiant Solo, this to me is a very important trial with a very rigorous design that was designed in very close collaboration with the FDA by taking out virtually all confounders that we've known to see impacting the results in previous trials, which resulted at the end in a trial that needed over 4 years to randomize 300 patients in 21 sites. So that already directly implicates the generalizability of these findings, and hopefully these results will be positive, but then even then results of other trials in patients on drugs, being the Radiance Trio and the Medtronic Simplicity Spiral on-med trial, are definitely needed to get a better understanding of the impact of this technology in patients on drugs, And even then, very little is to be said on how this technology will be performing in real-world practice. But for now, I think OFMED is important, and if positive, will definitely nail down the question as to whether this technology is effective in patients off drugs.
So you are the undisputed expert of renal denervation in our practice. Is renal denervation something that we need in our everyday clinical practice, or is it too early? Do we need more device iterations, or are we already there?
Well, and two things to be said. First, in terms of device iterations, I think we're not there yet. That also will be illustrated by the OFMED trial, which implies that in all these patients, a very extensive ablation pattern has to be achieved. We've seen that in a pilot trial, up to 40 to 50 ablations needed per patient, which result in very, very lengthy, cumbersome procedures, which can be very, very frustrating for operators and result in a significant contrast load. The Radiance and recourse system is slightly easier to use, but even there, efficacy rates are more or less in the same line. So I think there's definitely room for technical improvements. There's still no way to get feedback from a technical perspective paraprocedurally. And regarding your second question, do we need that into our practice? I think yes, there's a high need for therapies that will help us to control blood pressure. As you know, hypertension is still one of the leading causes of disease and mortality worldwide. That is highly underestimated and undertreated in local sites, but also expert sites like ours. And technologies like this, which are not that prone to be influenced by compliance, by operator preference, by guidelines that direct people into using different algorithms, is highly needed. So I think there's definitely a future for these technologies.
The UK TAVI trial is a randomized trial sponsored by the NHS in the UK and designed to address clinical effectiveness, but maybe even more important, cost utility of TAVI versus SAVR in over 800 patients of 60 years or above at intermediate or high operative risk. I'm not sure what data will be presented here, but would also hope to see some cost utility data. A potential limitation of the trial is the long time spent to enroll the patients, in which TAVI has dramatically changed in terms of valve designs and procedure execution. Don't forget, TAVI is now a procedure under local anesthesia with a shorter hospital stay than ever before. As always, thank you, Joost, and also thank you for watching and following this series on the major cardiology meetings. Stay healthy and please obey the recommendations, whether you personally like them or not, to help control this COVID-19 pandemic. We will come with an ACC wrap-up in the following week.
Stay tuned, and we'd like to see you for the wrap-up. Thank you, bye-bye, and see you next time.